Part of what we had to do for our teaching project was do an assessment of our site and come up with something that we thought would address a need. So knowing that we were working on this patient-centered plan of care, the one thing that I seemed to observe, and I also heard when I went around and was at meetings with Patty, is that we really needed to sell to the nurses the understanding to them that there's a need to change, standards of practice. And this isn't something new. It's something that's obviously gone on for a long time within nursing, but it's kind of giving the individual that global type of view where they can really understand where these changes are coming from. And I didn't necessarily want to have to stand in front of the class the whole time and lecture to you, so I wanted part of it to be interactive. I did not put all of my slides on the poster board, but I put quite a few so that people could get a feeling for it. So what I finally decided was that I would focus in on the nursing history of standards of practice down through time. But I'm not going to go back to ancient civilization. That's way, and let me tell you, once I got into this, I said, Natalie, what have you done? This is like the broadest subject, and of course, history is in the eye of the beholder. I needed to get the facts down for you in a point where, according to my perspective, I was bringing together elements that contributed to the practice, developing, evolving, and growing, and working on how to create standards. So it's my interpretation, and obviously you might disagree with me. So the definition, obviously, of standards, just to be a little technical when we start out, is it's an authoritative statement or expectation describing a level of care or performance common to the profession of nursing by which the quality of the practice of nursing can be judged. So that I found on the Canadian Nurses Association website. They have some interesting things. I don't believe in limiting myself just to the United States. And if you care to, afterwards, on the back of the poster board, there's bios of the pictures here, so you know a little bit of who I've chosen to put down as representatives of nursing leaders that help contribute to growing standards in the profession. I picked out this quote because I think it summed up everything that basically we're trying to help the nurses understand here at the medical center, and that is that it's self-evident that an occupation, and especially a profession whose services affect human life, must define its function, and nursing's attempt to do so has a long and still unfinished history. So Henderson, interestingly enough, I didn't know it, the architect of nursing and mother of all comes from her epitaph that's on her gravesite, and because of her immense contributions to nursing in terms of nursing theory, and she's probably known as one of the people whose definitions of the practice of nursing has stuck with a lot of people, she sort of became known as this mother of nursing. But I think the point that I'm trying to get to is that our history is unfinished. It's always going to evolve. It's always going to define itself according to the historical context and time period that we're in. Now, my professor, who happens to be Dr. Lewinson, I didn't put that in there to get brownie points, but it was a good quote. She's a big history buff, and basically, she has said to us that, history teaches us who we are. We as a profession need to understand this because history offers an identity that we can use to grow and evolve. So a lot of what happens in nursing, even though we're evolving and changing, we have to look back to our past, and we have to understand the roots of where it came from and why we're in this position today. And looking at standards, as I said before, I had gone to this Canadian Nursing Association site, and they had described that nursing is a self-regulating profession and that the standards are set out detailed expectations against which practice is measured in order to protect the public. So it's expected of us by the people we serve, by our patients, by the public, that we're going to be looking to ourselves and correcting areas where we see we need to do better, and come up with standards that are going to address the complex problems that we have today. The profession, interestingly enough, it kind of grew out of war. That's the sad commentary of it. But prior to the Crimean War, which was England's war, and Florence Nightingale going and raising the standard of care for the soldiers, and really, she was a very educated woman. She believed in empirical observation. She would write down everything that she saw, and then she would go back and analyze that data and look for trends and try to see ways that things could be influenced. She was so revered by the British when she came back from the Crimean War with everything she had done that they gave her money to start a nursing school, and that's what she did. And for here in the United States, we really didn't have any nursing schools, even at the start of the Civil War. So I have that over on the timeline. You can see it better. And like a lot of things, one person in wanting to be so involved and motivated towards making their contribution, she managed to talk herself into the position of being the superintendent of union nurses, and that was Dorothea Dix. But she was actually a trained teacher, so she had no nursing background, no nursing knowledge. It was more or less, at that time, sanitation and hygiene were starting to be more focused upon, and she wanted to make sure that these standards were starting to be implemented in the battlefields. So the Civil War started to really prompt the growth of nursing programs, and the first one opened up at the Women's Hospital in Philadelphia. And then it was followed by many others. So here's the timeline. Now I decided, people are probably saying this is a nursing presentation, but I did want to bring up the fact that the National Academy of Sciences, which we know the IOM will springboard off of that later on, started in 1863. So a lot of changes that have gone on in healthcare have really gone on in a very compressed time period, because even Nightingale did not know when she went to the Crimean War that a lot of disease was caused by microorganisms. It was just being discovered at that time, and science was starting to make rapid advances, and Lincoln wanted to see that there was some type of body that would be accountable to the public in terms of looking at what was going on in science and research. And it wasn't until 1970 that we ended up getting the IOM from this. In 1873, so again, it's a much later time period than Nightingale. You finally had 3 nursing programs that were official schools that opened up. And in 1896, we had the American Nurses Association got started. There was basically a group of women who had graduated from some of these hospital programs, and they wanted specifically to come together. They wanted to establish their professional identity and look towards establishing standards of practice. And we know in 1900 is when the American Journal of Nursing was first published. So that's a very long history when you think about it now. We're up to 111 years. There was no type of laws about how nursing would be regulated. So beginning in the early 1900s, and New York was a leader in this area, you had states who now said we have to have some type of registration laws. So things were not standardized, but they kept moving in that direction in terms of education, licensure, but it still takes a lot longer for things to keep coming together and be standardized across the country. And at the same time, the National League for Nursing had been founded, and they were the ones that were looking at, like, okay, we have to now make our curriculums in schools standardized, because there's a lot of variability. You could go to a school and you could have some training and you could come out being called a nurse, and it would be different from what somebody else might experience in another format. I wanted to point out about Teachers College that Isabel Maitland-Stewart, she was one of their first deans of nursing there. She was very much interested in research. So as early as 1928, she was able to have Lincoln Hospital in the Bronx work on a time and motion study. I found that very interesting because we're in the middle of the Industrial Revolution, and there was a lot of looking at manufacturing and timing and how things could be done more efficiently. So, already in higher education, people are parlaying what they see happening around them historically, and they're trying to figure out how to incorporate it into research. I bring up the Social Security Act because this is really where hospitals now burgeon and grow in the United States. So I can remember my parents would say to me, this sounds really strange, but I now look at it very differently. You never went to a hospital when you were sick. And that is because hospitals were not places that people got their care. They got their care in their own home by a family member or by a private duty nurse. And so what happened is when the Social Security Act was passed, it released more funds for people to have during their old age or if they had dependency needs. And this allowed for a greater number of people to have the financial means to be admitted to hospitals, because at the same point in time, paralleling this is the fact that the medicine was coming up with its advances, and so they were discovering microorganisms, antibiotics were starting to be discovered, and surgery was now being more accepted because they could put people out with ether gas and operate on the hospitals. I have to take some big jumps in time here because I'm telling you, when you go online and look up the timelines for things, you're really just amazed by it. But the American Nurses Association, it took them all the way up to 1950 to develop their code of ethics. So they actually started in 26, and then in 40 they had a tentative code, but people just didn't come to agreement until 1950. But again, it's that push towards looking and saying, we're a profession, we need to know exactly how we're going to state our obligations to the public. In 70, as I mentioned before, the Institute of Medicine was founded as a separate branch of the National Academy of Science, and its advisor to the nation to improve health care. Now, I found this to be a very interesting fact because the ANA's first published standards of practice did not come out until 1973. So there was a lot of people getting together and trying to formulate standards, but again, agreement and consensus didn't happen until 73. But interestingly enough, at that same time, you finally had the first National Conference on Nursing Diagnoses. So this was going to better help define the scope of nursing practice and its knowledge base. The ANA fought for years. This took years for them to finally get NIH to recognize having a separate department to do nursing research. So, this really was elevating our status as a profession by saying, yes, you do have a unique body of knowledge that needs to have research be conducted in order to have best practices with people in the future. Now, the end of the 20th century and the beginning of the 21st century, we have a lot of things happening at the same time, and this is really going on because of the need for issues with safety was coming up, quality, because we had in the 80s implemented the DRGs in the hospital so people were sicker and coming out of the hospital quicker, and satisfaction was also beginning to play into this because with modern medicine, people were not happy with their hospital experiences. So the National Database of Nursing Quality Indicators, again, ANA saying, we want to be able to track and follow and see what is happening in different institutions so we can start measuring and comparing quality. And by '99, you had the IOM releasing several reports to err as human, building a safer health system was the first one that pointed out the tremendous number of mistakes that were being committed in healthcare each and every day across the country, and what that was costing us in, not only increasing morbidity, but also mortality and financial constraints. And then it was the crossing the quality chasm, a new health system for the 21st century that really laid down the foundation for what the IOM was going to say was going to be the 6 aims of improvement in healthcare. I brought in the HCAHPS because this was in direct result of the dissatisfaction that patients were feeling, the issues surrounding quality of care, and so there was a lot of research that went on to create this standardized assessment tool. And it was first released in 2004, and in order to get hospitals to comply with it, as you know, there's a financial incentive because you won't get the add-on for your IPP, what is that called? Your rates. It's like a 2% increase is automatically denied across the board if you don't participate in HCAHPS. But what we're going to be leading up to is that the final ruling, which comes next year, where now your HCAHPS are going to be tied into your patient satisfaction. And this is an area that obviously you're not the only facility in the country, because if you go online, everybody is trying to figure out how to work with their staff towards improving patient satisfaction. Also, it's interesting, but scholars feel that there's a definite relationship between the release of the Affordable Care Act in 2010 and the IOM Future of Nursing report, because the individuals that were associated with the IOM report started as early as 2008. And if you think about their political ties and what they were hearing in Washington, they knew that nursing had to change and expand its role in response to the Affordable Care Act. So it's not dismantled by the next administration. It's going to create unique opportunities for practice with nurses. So these were the 6 aims of improvement that came out of the 2001 IOM, and I thought it was very important. I arranged this myself because obviously, it's just basically listed, but I put patient-centered care in the middle, and that speaks to then being able to pull in all of the other elements that the IOM says facilities, must focus on if they want to have improvement. And a quote from that report is that all health professionals should be educated to deliver patient-centered care as members of an interdisciplinary team which emphasize evidence-based practice, quality improvement approaches in informatics. So the other thing I wanted to do is I wanted to go online and I wanted to find, could I find any best practice nursing guidelines for patient-centered care. And I don't know why it's the Canadians again, but the Canadians are the only ones that have released patient-centered guidelines back in 2002, and they have also updated it as of 2006. And of course, a lot of the evidence within the guidelines is not, your highest quality evidence. A lot of it comes from qualitative and quantitative studies, but I think what's important is that people are seeing that there's a need to put into a guideline what are the best practices that nurses can engage in. And the patient-centered approach, it's really been a part of our history, but I think it got forgotten down through the years because of how technical nursing became and just how the everyday job for a nurse is very stressful. So as I said to you before, the Affordable Care Act and the IOM are linked, and it's not considered a coincidence at all. And We talked about the HCAHPS and what was the purpose of collecting the data. So from here, I'm kind of summarizing things that you do know in terms of the goals of the HCAHPS. And obviously, the transparency, because you all know it's posted on a public website, is available to the public because you can just punch in your zip code and ask for some hospitals in that area, and you can see exactly what's going on. And this was the driving force because a lot of time went into preparing the tool and making it standardized so that you could use it from one facility to another and it would have meaningful data for people to read. So the actual questions are available online, and the three important ones that I know people have been focusing here at the medical center is during your hospital stay, how often did nurses explain things in a way you could understand? Okay, so you've been doing your scripting because you want to be able to help the staff enhance their communication skills. How often did nurses listen carefully to you? And how often did staff tell you what a new medicine was for? So everywhere the literature is showing that hospitals who've not prepared their staff on ways to make the patient the focus of care will be a distinct advantage. To the point where you can find some literature online where, you know, some nursing groups are very against this because they feel that the focus on standardization, like particularly in scripting, is not allowing for a person to have a unique individual relationship with a patient. But you can argue that point back and forth many times. So the implications for the practice here is that, you know, current practice should not be based upon what nurses have always done. So, you know, you've had to have that cell, you've created that group of champion users who were the first ones up and getting familiar with the new nursing data assessment. And you use the research, obviously, to suggest alternatives to practice. So I think a lot of that has been in Ann Tarpey's domain. The information has been shared, a plan has been developed, and nurses are being assisted to understand why the change is necessary. I'm sure there's still plenty, just because it's a huge audience that you're trying to get out to, that still really don't understand, you know, why are we doing things this way? But it's part of the ongoing education because Mary had said in a meeting the other day when she was meeting with the consultant for Joint Commission accreditation, and he said, you know, what's your biggest challenge? And she said, sustaining change. That, I mean, doesn't that just say your job in a nutshell every day? So evidence-based practice, you want it to guide your nursing care, you want it to develop in accordance with the needs of society are. And we realize that, you know, the complexity of today's healthcare setting, along with the limited resources, has really pushed this drive for bettering outcomes. And part of what's gone on is patients have been feeling very alienated. So that shows up immediately in your patient satisfaction scores, because if they can't say that, you know, somebody took the time to talk to them about their medicines, or somebody took the time to explain their plan of care, then something's wrong right there within that process. So what I did here was I adapted a model to kind of show what the Registered Nurse Association of Ontario has done in terms of the factors they call success for patient care. And you can see it's a circle because it's basically ongoing. You know, there's not necessarily going to be a break in this process when you're trying to sustain change. So the first thing that was done here was the implementation strategies. You know, you had to come together, and I think, Mary, you told me it took 6 months to change the nursing assessment database and EMR. So, you know, that was a whole bunch of strategies coming together at that time. And then, of course, you have to have your ability to plan, resources and support. So that's been all of the things that you ladies have done over time to help this initiative. And then there's shared leadership and planning. And I can tell you, now that I've met Patty, it's definitely shared leadership. You feel such responsibility for this, because this is so huge for you all. If you don't have any effect on your satisfaction scores, you know, you're going to be getting less reimbursement in 2012. There has to be a cultural shift. So I think that's what we're seeing taking place right now. And you have staff, because of the champions that are out working in the units, who are trying to help support their peers. And when each of you take the time to go around and talk to them about the plan of care, how are they doing with creating it, you know, what's their problem list look like, is it stated in nursing diagnoses? Each little bit of that one-to-one mentoring is helping with the cultural shift. And then you have your ongoing continuing education and professional development, which may change your strategies again. So that's why I liked putting it in this format. So this basically, I summarized quite a bit here, your own internal process. So I don't want to go through this, but it talks about how your electronic medical record is bringing together the data for the nurses and developing the problem list. So I ended up putting it in graphically so that, you know, the EMR database collects and, you know, basically targets and triggers problems in either a condition set or a system set to finally get to your problem list. And this is supposed to help the nurse in their practice every day. And as Ricky's presentation was about, you know, it's really working with that problem list each and every day that is going to make the difference, because the staff have got to understand what are they doing. You know, they can't necessarily be focused on one specific task. They need to understand, you know, what is the nursing diagnosis for this? And, you know, the database for that, as I mentioned before, was created in 1973. So there's been a long time to refine that and to get the nursing diagnoses in there to have sense and make relevance, and now it's focusing your interventions for your day around that. And it might only be one thing you can get to. So I wanted to conclude. Mary should be here. I'm not sorry, not Mary. Ann Tarpey should be here, because the Sturter Group is a national healthcare consultancy, and they have about 800 clients across the country right now that they are literally trying to help with hospitals improving their patient satisfaction scores. So I'm sure that is a group that Ann Tarpey is familiar with. But one thing I found, again, by searching the literature, is that, you know, nurses are not generally prepared to communicate with patients on a range of situations. We like to think that when we can walk into a room, that every encounter can just be spontaneous and we can go in and say and do what we have to do. But the reality is that if you don't go in knowing specifically what you need to say, and you have had the opportunity to practice it as the nurses are doing in the scripting class, you're not going to do it, because you're just going to automatically default to the old ways. And actually, the American Association of Critical Care Nurses became very much interested in communication, because they basically said that nurses have to be proficient in communication as they are in skills. So it's not an option anymore. It's becoming a necessity that people understand, you know, what is driving this, because it makes a difference not only with how your patient feels about that particular episode of care, but also it's going to make a difference in outcomes, because if we're not all communicating clearly to one another, then what happens is you have a greater chance of errors being committed. So I was fascinated the other day, because I was in a meeting with Mary and a nurse from quality assurance, and it was all about standardizing your shift report. So Patty wants the nurses, when they give report to each other, to give it in a format that brings in the nursing standards of practice while the report is being given. So that's how much this level of communication is penetrating, because if you think about it, this is something that any nurse, whether it's going to be CMS or whether it's going to be the Joint Commission, can get stopped by the surveyor, and they need to know this. They need to be able to recite this. They need to be able to say it, because it's really the only way you can prove that your practice is standardized. Otherwise, you know, there's a lot of variability, and that's what people are looking for. Standard of care is the same, no matter whether, you know, you're a suicidal patient and you're on the med-surg floor, or you are somebody who has a problem where you need to have surgery, and you end up being transferred to a unit that doesn't normally, you know, handle post-surgical patients just because of, you know, bed space and bed issues. It's got to be the same standard of care, so the nurses have to be prepared for this. So, questions?